Soccer. It is a Pan-African Friday, and of course, joining us in studios today, two very important visitors or guests and experts at what we're going to discuss. Now, in studios this morning, we have Dr. Jackson Orem, the Executive Director from the Uganda Cancer Institute. You are very welcome, Dr. Orem.
Thank you.
Thank you for allowing to join us on our Pan-African Friday.
Thank you. It's a pleasure being here.
Thank you very much. Now, together with Dr. Jackson Orem is Professor Vinand Nantulia. Now there's another Chiganda name that I keep forgetting. Let me leave it. You're very welcome, Professor Nantulia.
Thank you, and thank you, listeners.
Thank you very much for joining us. And of course, together with my usual co-panelists, Tuta James, Karibu, and Coleman Amazima. Karibu. We're going to talk about health systems in Africa, and of course, looking at our responses to the different or the various epidemics or pandemics or the health issues that keep coming by, and see how we are managing our health issues on the continent. And of course, it is where we are. Mututa, Karibu, and before we get to the guests, let me first pick your thoughts, and let me first hear from you and your simple review of the week.
Yeah, the week has been a bit calm, and I think already we are getting information that the lockdown has helped in reducing the number, the number of infections, but also the number of deaths is also going down. You remember, by last week we were told that the curve was such that there was a reduction in infections, but deaths were still high. So by the end this week now, we are being told that the deaths are also coming down, which means that the lockdown has also had its own positive effects on the fight against the pandemic, and I think that's very positive on both ends, by the government but also by the adherence for those who have done so in the public. And I think, like we had discussed last time, that if we continue at this pace and this trend, it is likely we'll see more reductions in both infections and deaths, and maybe our curve will be somehow flattening. So, but it has been a relatively quiet week, but also busy, because a lot of things are happening. And then of course, on a lighter note, you also had the issue of the death of the president. So it has been a bit...
That never was, yes.
That's the type of the week that we have gone through. But on the overall, I think we are moving towards a positive end. And I think talking back on the issues of health and Africa, I think we are moving in the right direction. Okay. But I think, and I continue appealing to the public that let's adhere to the SOPs, because at the end of it, government doesn't die. It is us, the individuals, who actually are affected and die.
Thank you. Marco?
Well, I think the week has not been so bad, apart from the sad news coming in from our cousins, that is in the Americas, Haiti. At a time the world surely is fighting a pandemic, their politics are going wrong. Their politics are going wrong, and so much that we saw the president and the first lady actually being assassinated. Yeah, it is our prayer that actually they come out of this, because if it is not well managed, they will have a crisis of fighting the pandemic alongside now what is looming as a civil war, if they really don't work out around the clock 2 years to make sure that they handle the situation. But also the other issue was the burial of Super Ken. Yes, the founding father of Zambia. We saw President Uhuru Muigai Kenyatta from Kenya, really among those really who went to see him off, and I think he's the last of his generation, really those who participated in the liberation of this continent. And how I wish that really we could actually borrow best examples, because actually even during their time they had pandemics, they fought, and they successfully really did fight them.
Okay. Well, thank you so much. Welcome, Professor Nandia and Dr. Jackson Orem. We just had to look at the week as we've also been seeing it and participating in it. But now getting back to our business and discussion today, let's hear from the experts. First and foremost, how we are actually managing where we are, because this is a time where we need more of you, the experts, the doctors, to keep guiding us, talking to us, and it's not time that we actually want to listen to the other people. It's time now that we need to zero onto you. How are you managing at the Cancer Institute and through this period, of course?
Yeah, thank you. I think this pandemic actually has kind of brought a very big question that we need to pay attention to. That is the importance of health in as far as our livelihood is concerned. And it is unfortunate that it has to take a pandemic or a situation like this one to kind of make us appreciate health as a very important component of the fabric of a community. Because without health, you cannot do anything. You cannot imagine that, you know, all the big dreams that we have as individuals, as countries, as region, or even as a continent, all those dreams now have to take a back seat. We must now focus on health. Because without being healthy, we cannot say, you know, we are doing anything or we are being productive. Anyway, that is just to state that it is rather unfortunate that it has to take a pandemic to kind of wake us up to see that health is the most important. Now, we are in the middle of it. What do we do? I don't want to go into what is being done, which is actually common knowledge. We are doing our best. But at the same time, also, you will realize that if we are to segment the different aspects of health, then you need to prioritize. And with that, that means that there are certain things that must take a back seat because you want to kind of do certain things first. And when it comes to areas that have taken now a back seat, we realize that we were making some strides in the control of what we call non-communicable diseases. These are actually the emerging problems that are now coming as health problems, especially in the developing world. You talk of cancer, you talk of diabetes, hypertension, and all that. And usually they actually require intensive investment, and they also require a lot of thoughts to put in place a system to manage them. And I can assure you, those systems were very fragile. In fact, in most countries in Africa, they were not in place. So they have collapsed because of this pandemic. Yeah. Now, coming to us as Uganda, and I can speak authoritatively for cancer, I want to congratulate ourselves. Because as a country, I don't know whether by design or by luck or by whatever, we have a system in place that has been fairly robust. Because in most African countries, and actually not only African countries, most developing countries, and even some developed world, cancer services have collapsed as I speak. First of all,
because of the pandemic.
Because of the pandemic. They don't have drugs, they don't have the health workers. All the health workers have been rallied to respond to
COVID-19.
To COVID-19. So that means cancer patients have been left now to die, actually virtually.
You save them from COVID and cancer kills them.
Absolutely, yeah. But that has not been the situation here in Uganda, and you can attest to this because you haven't had any outcry specifically for cancer. Our government has put in place a system. We kind of run a model we call a comprehensive cancer system. That means that we have cancer as a focus and resources put. It may not be enough, it may not be much, but there's dedicated resources towards the fight against cancer. And it is actually that, together with the system that we have put in place, at the center of that system, of course, is the Uganda Cancer Institute. We never closed our doors to cancer patients during the pandemic, up to today.
Up to today.
People are getting their treatment. They are being inconvenienced a little bit because, of course, you know,
curtail movements.
Exactly, movement, exactly. But the service is there.
For as long as they can move from where they're coming to the Cancer Institute, then they are assured of support to health. Well, thank you. Professor Nantulia, you are the people now that we're looking to for solutions. The rest of us, President Museveni refers to us as Shakespeare's. He doesn't need Shakespeare's any longer. He's now talking to scientists. And it is a time that the rest of you need to give us solutions. But Dr. Remia makes a very important submission and saying we need to look at it as very important and not wait for such situations that we now need to know that, oh, we have a problem, our health systems are fragile, our health systems are not as robust as I thought. It shouldn't take a pandemic to come for us to do the right things. But let's hear your thoughts on our systems in health.
Thank you. Health systems, the health system is the backbone for a national economy. There has always been a misunderstanding that health service is all consumption. You provide the money, and you never see what the returns are. And that argument is really old-fashioned. We know, and the pandemic has given us a very good lesson, that you ignore health and you have an economic catastrophe because you need a healthy population to be productive. Now, what's the problem with the health systems in Africa is that they are actually under-resourced. When you talk to ministers of finance, ministers of development, they will tell you that, okay, we have increased the budget of the Ministry of Health over the last years and so on. When you now bring in the real measure of investment in health, which is the per capita investment, how much money is it per head? When you look at that graph, in fact, the contribution to health has been going down, because the population has increased. Number of diseases have come in that were not there before. And you find that a lot of health systems in Africa are actually crumbling because they are not able to withstand pressure. And this is the argument we want to make, that it's important to invest in health. Now, we have two types of health systems running around in the world. You've got the American system, which is driven by private sector and insurance companies. And our advisors come from there and they tell us to do the same, and they are wrong. Because the best health system in the world is run by Cuba. And why is it the best health system? It's anybody can receive any health care at any one time, because life is important. Everybody's life counts. And that's the system in Cuba. It doesn't matter what problem you have, you'll get the service. Why? Because the state has invested in that, in building it. And it costs money. Now, when you take the American system, that's different, because there it's business. And it's a system which the late Robert Kennedy fought all his life, and he died before it could be achieved. He passed it over to Obama, and Obama brought in the Obamacare, which Trump came and destroyed. You know, it's about making it possible for anybody to get health care, regardless of social status, regardless of economic capacity. Okay. In Africa, we need to take a system which is different. Let's take a system which is based on public health. Let everybody be kept healthy at home. Provide what is required for the person to keep healthy, so that we leave the health facilities only for repair of the health that has broken down. If we organize it that way, we can manage. But if we don't, we shall never be able to manage. At the beginning of the fight against the epidemic, Uganda's approach was exactly the right approach, which was prevent, prevent, prevent. Prevent people from getting infected, prevent infections from coming in, and prevent
it from spreading in the community.
Prevent it from spreading among the people. That's what we did. It worked very well.
In the first phase.
We were number 10 in the whole world among the countries that were doing the right thing. Then we relaxed. We relaxed. And now that's when the catastrophe of the new variants came in.
We are now about amongst the top 10 now.
Yes.
Causing the load now.
Exactly.
The African load now is we are among the biggest contributors.
We are among the biggest contributors. Now, it's not about, and as we argued at the beginning, it's not about waiting for patients to come to hospital, because we would never have enough beds, we would never have enough oxygen, we would never have enough medicines, enough people in the health system to look after people that come to hospital.
That is what people are actually talking about. That when we went into the first lockdown, the prevent method in there, we anticipated. Now, the rest of us who know nothing about these things, I thought that there would be enough beds, there would be enough oxygen, there would be enough ventilators. At that time, actually, the issue of ventilators is when many of us actually heard about ventilators for the first time.
Yes.
We heard about ventilators, and we even couldn't, the ventilation that we know is
different.
For the hospitals.
Yeah.
And you know, we even do not know whether we had any ventilators in this country at that time. Now, when we've had this second wave with the problems embedded in there, everybody is saying, you locked us down to have enough oxygen. Would we ever have enough oxygen, even if we locked this country for 3, 4, 5 years? Would we provide enough oxygen? Would that be the solution, Professor?
So, as the president said the other time, and he was asking Diana Twine, I ordered you to prepare for 42,000 beds. Where are they?
Mwanjemera. They only produced about 3,000 or 4,000.
Yes. So, was this expected to come? Yes, it was expected to come because it was already happening in Kenya. So the president was right to say, let's also start preparing for hospital care. But somehow the system didn't take this on board, and we have ended up with a crisis, and we're not prepared for this crisis. Now, we shouldn't be depressed about this. Yes, let's get moving. And we are moving. And we are moving. More hospital beds are being made, Namamba is being organized, etc. And at the same time, we have brought in the idea that we should improve on home-based care management for the patient. Because we know that the vast majority of people that get infected, they don't need hospitalization. They develop simple symptoms which can be managed at home. We knew that, and we needed to put this in place. Again, we delayed to put it in place. Otherwise, it works. And then you leave those that need to be taken to hospital. But only if you have got a good community-based system for looking after the home-based care and for identifying those that need to be referred further up.
20 years ago, Professor Nantulia, the problems that we were battling with as a continent was HIV/AIDS, and of course malaria, tuberculosis, and quite a number of these. And presidents, heads of states under the African Union, of course, convened in Abuja, and they had the Abuja Declaration.
Yes.
And they made a commitment of financing our health systems on our national budgets up to about 15%.
Yes.
Now, a review was done, I think, in 2018, and just about 2 countries on the continent actually managed to do that. But one of the challenges embedded in there was the informality of our economies. Most of us are very informal in how we actually do business and financing domestically and do all these things too. And we've not managed to get to the threshold. But even then, even when we've not achieved the 15%, what we need to ask now is, has there been any difference from 2001 to 2021, 20 years later? We may not have achieved that because the 15% was supposed to be achieved by 2015. We did not get there. A review was done in 2018, and just about 2 African countries had actually gotten there. But is there any difference from when it started to where we are today?
The difference is that the initial funding we were getting, if you expressed it per capita, it was higher than what we ended up with. Because the population increased, pressure for services increased, and those were not taken into account by the Abuja declaration. Yeah, because it was based on a gross budget allocation, not considering the per capita consumption of health services. Yeah. So in terms of per capita consumption of health services, the health system has been down. It's been going down. Yeah.
Yes, and I think it has actually been going down. Even those that had tried to achieve it, but of course it had to come down a little. What we need to do, Dr. M, in as far as financing is concerned, because we have these issues, and now we also have a specialized health issues. When we talk about cancer, we're not talking about mild, simple COVID symptoms that somebody can actually go and manage from the home. We talk about something very complicated, and I don't think you need the same nurse to manage you for COVID to also do the same when it comes to an oncology affair. What do we need to do with that?
Yeah, I think Professor Nantulia made a very important point about the health system that we are operating under. And you may, even if the countries in Africa decide to by now allocate adequate budget up to maybe the 15% you are talking about from the Abuja declaration, without a well thought out health system, that budget will not actually achieve much. And actually, Professor is very right that despite the fact that, if you look at the gross funding that was being given, especially for the HIV fight, it was quite much. But if you kind of break it down to the per capita, and in addition to that, you factor in the population increase, you'll find that that is actually not much. All that is because if you don't have a good system, however much money you are going to put into that system, you are not going to get the outcome that you expect. So, in fact, we need to go back to the drawing board and re-engineer the health systems in Africa. The point that is making about managing patients or health issues at the population level is very important. Do we have a system that responds to the population in that manner? For instance, if in our village a patient or a person gets a health issue, how quickly can the health system respond to that emergency? It is all about the fact that there is a disconnect between the population or you can take it as the public and then the health system. That disconnect actually needs to be thought out very well. And that is what Cuba has done, the example that he's giving. Because in Cuba, they know the need of every member of the population in as far as health is concerned. They even know which child has not been vaccinated.
In Cuba?
In Cuba, at the lowest level, which we do not have. And that means, despite the fact that maybe they can allocate a certain amount of budget, they can actually account for every coin in as far as health is concerned. But to the point that you are asking me, if I were to give a proposition, I'll say that let us kind of take a step back, hoping that we are going to come out of this pandemic. The lesson that we are going to, it should not be business as usual. We need to sit and rethink our health system. And there is now a lot of buzz about universal health coverage. Actually, the examples of universal health coverage is already there. It is already being practiced.
UHC.
Whether you are in a high income bracket in terms of countries or at a low income level, we already have examples of success. In the high income bracket, we have the National Health System, or NHS, in the UK, working very well. You go to Sweden, they have a system which is actually driven by the public need. It's the public system which is providing care for the population. Then, of course, the low income bracket, we have Cuba. They have a fantastic system, which is actually a very good model for the universal health coverage. So what we need to do is we need to sit back and try to study these systems and come up with something which actually responds to our need. And within that, the question that you are asking, the answer will come. It will cater for the infectious diseases, the malaria, the HIV, etc., that are actually very prevalent. It will also cater for the sophisticated diseases, the cancers, the hypertension, the diabetes. And in that way, that is what the essence of a universal health coverage is. It caters for all the members of the community, for all their health problems, irrespective of the disease conditions that they have. There is no need to categorize and say, because you have cancer, no, we are going to say, take the back seat, let us first handle somebody who has malaria. If you do that, that means actually you are not having, in essence, a good health system that is adhering to the principle of universal health coverage.
Let me give you some feedback on top of what Dr. Riem has said. And let me use my advantage of gray hair and loss of some hair to let you know that many years ago in Uganda, we had a very fantastic health system.
Many years ago.
Many years ago, we had a health system which was fantastic. What was it? It was run like this, that in every sub-location, every Gombolola, you had an engine for health, because health is broad. So you had someone looking after agriculture. There was an agricultural assistant. There was a public health assistant. There was a veterinary assistant. And there was a nutritionist. And that engine was supported by the chiefs. And their job was to move from house to house to ensure that every house, the housing is being constructed correctly, the windows are there. They needed to see whether a home has got a plate stand, so when we wash plates, you can akatandala. They needed to be sure that every household had the pit latrine, which was decent and being used. They needed to ensure that there was a road leading to the compound, and they needed to ensure that the compound is kept clean. This was done by that engine of development. They visited the schools to see that the schools were set up properly, that children were having lunch, porridge for lunch. They made sure that the parents were supporting the schools, and that the schools were teaching children how to keep healthy. This was the engine at the lowest level. That engine would mobilize people if vaccination is needed for children or vaccination is needed for adults. So you had the smallpox, the wart, the polio, and so on. That was the engine. The chiefs were trained. They were part of the civil service. They were trained in community development. And this we lost. Now what you have is LCs elected. You find an LC1 chairman who does not even have a pit latrine. He's an LC1 chairman.
Doesn't even have a residence.
He does not even have a residence.
He's a tenant in the area,
Yes.
but he's a chairman.
Yeah.
Because somebody can default on your tenant.
Yeah. This is how we have lost it, because the other system was well organized and it had accountability up to the center. During those days, you qualify as a doctor or a nurse. They don't post you to your district, home district. You are posted elsewhere and you rotate, and you are promoted as you go along. By the time you come to the headquarters, you know your country and you know your country health system. That we don't have now. So there are problems in the decentralization, problems where you will find that an LC5 chairman has a child who is in a third-year medical student, and so he will keep the position of a district health officer vacant until the son qualifies. This is going on. So we need to rethink how our health system is run.
I want to thank you on that note, Professor Nantulia, and let me bring in my two gentlemen here and talk about the decentralization policy now. From what Professor Nantulia here submits, you notice that what he's talking about many years ago when we were not here, he was here. He's talked about quite a number of things, the public health assistant, the graduate assistant. We grew up hearing many of the things, PIDA and stuff like that. When we decided to decentralize, our decentralization policy, I think of 1992, gave us a very good system of decentralization. Over the years, we can all attest that we have politically decentralized and we have not decentralized in the other affairs, because today, in every village of Uganda, the 70,000 villages of Uganda have an LC chairperson. Every political office, every elective office today as we speak, like he says, is represented. We can afford not to, I think, have a district health official at the district, but we cannot afford to have a district health chairman. If there's no district health official, many of us will not even know. But for as long as we do not have a district chairperson, a political leader, there will be public outcry of why don't we have a chairman in this area. What we think needs to be done on that note of a decentralization, which I think also will help us manage our health systems, as the two experts are saying, Akol.
Yeah, I think decentralization is one of the things that has done more harm than good in Uganda. Yeah, because first of all, like some have already said, somebody grows up in Mbarara, goes to Mbarara Primary, goes to Mbarara High, Mbarara University. In other words, when he finishes, he works in Mbarara.
District
So he will never even appreciate the fact that he's a Ugandan.
His world is in Mbarara.
His world is just within Mbarara. And that denies him the fact to appreciate the entire country. We also saw recently, actually, there's I think a proposal that they should scrap district service commissions, because like Professor said, you're chairman LC5 Uganda, you have a son who is in third year, you'll keep some positions vacant until you
because your son is in medical
school, and you had to be the district health officer. But remember, he does not even have the experience to head such kind of office. So that I think is the dilemma we have with this decentralization, that we are talking about building a nation, building regional blocks, and perhaps coming up with a Pan-African continental outfit. But if this is how we are going to go, then you have people really who do not even appreciate being Ugandans. So that is the bigger crisis. But also on the other issue, when we come to the issue of health. The issue of health is really very, very important, and they've given an example of Cuba, because every other time we hear about Cuba, we think about Che Guevara and then Fidel Castro. But how I wish that now we look at this, their health system, because here in Uganda, at a time when the doctors wanted to strike, and in Kenya, President Uhuru Muigai Kenyatta and President Trump said, okay, if you don't want to work, we're going to bring in the Cuban doctors. But the question is, how are these doctors trained in Cuba? They are trained primarily to save lives. But now here in Uganda, I think most of the people who go for medicine, the motivation is that it is the cost that will make you rich quicker. That is why, even as a patient, even before you can open your mouth, you must pay consultation fee to the doctor. So I think these are some of the things that we also, the training has to change. That the primary motivator for one to go and do medicine should be to save lives, not a course that is going to make them richer and live a better life within a short time. I think that mindset ought to change. Then also, secondly, let us also look at our communities. Let's look at our communities, because communities, we are more into political leaders than other service providers. Like Kayunga has just lost a chairman, LC5, and everybody's aware. And they say, yes, there is a vacancy in Kayunga, and people are starting running around. Uganda, we lost the other day. We lost our representative with the East African Legislative Assembly, and that one is clear. But there are districts that actually are running without those DHOs, healthy workers. And it has been on for around 4 or 5 years, and no one is even bothered to say, look here, but how is this running? You find that this grade 4, grade 3 health centers are running in miserable states, but no one is bothered. But people will be quick to say, our MP has not been coming. They will be quick to point out that, but they will be slow at pointing out that our health center is not working. Okay. So let's also have a population that is also vigilant about what belongs to them. Okay. Because ideally you may actually you may do away with that. You may live without an MP, without a chairman LOC5, but you're not going to live without a health center.
No, we've not realized that we need the doctor there.
Yes,
we
so,
need the chairman there.
So those are some things. Then lastly, I also think that we should also strengthen our African brotherhood. Because there was a time when we had the very first lockdown, there was some ugly scenarios, especially people living at border areas, that people in Amdat, actually, when they fall sick, they get medication from Kapenguria in Kenya. People in Bukwa, the same thing. It is in Kenya, but now the borders were locked. Now, people, when you come to places like Kasese, in Bwera, people in Eastern Congo, in Kasindi, Beni, actually get treatment from Bwera Hospital. Now, when the borders were locked, you can imagine how much damage it was. So I think these are issues that bring to the fact that as Africans, we are interdependent. Okay. That you'll find, especially the border communities, that you find that they will always depend on services in the other country, and that is why we have to strengthen these services, not for our own not for our own sake as Ugandans, Kenyans, but for purposes of the Africans here. And then lastly, we could also learn from India, because India, they are reaping a lot of money from actually the medical tourism. Every year, how many people go to India for treatment? So many. So why also people who go to India? And what is so interesting is that most of the people who go to India are actually policy makers. Yes, it is not the wananchi, what the Kenyans call the wanjikus. No. It is the policy makers, either they are taking a cousin, they are taking a mother, they are taking themselves.
Or
it's about themselves. But when they come back home, I don't know why they really don't learn the best practices that they can bring them home.
Mututa.
Professor talked about the systems, the health systems. And something comes into my mind. We have American system. We have the other system he called
the American system.
Yes, but do we have the African system? And as a community, as a population, do we ever have had a system? True that Africa has had the most effective health system, even before the colonialists. We had the best biomedicine information, even at the community level. And Africa has contributed a lot in the medical world. In fact, that by the time the colonialists were in Africa, African surgeons were carrying out operations without going to any university, but they were doing that. Now, when you look at the way the midwives of Africa were doing their job excellently, they could tell you this child is going to be problematic at birth, this pregnancy has issues, this child is a boy or a girl, even before the ultrasound machines came. But where did we go wrong? Of course, the first thing was that the colonialists did that to dismantle that knowledge by displacing African populations and then societies will forget or lose contact with the type of medicine they used to have. But still, Africa has continued to play an essential role in discoveries and treatment of a lot of these diseases. Talking about like a sleeping sickness. Africa did a lot. Diseases that have been like smallpox, of course, and the other plagues. But the problem is that I think much as the colonialists didn't allow Africa to progress, to be assisted in promoting and studying the systems of Africa, we have also, I think, given up on a lot of things that ordinarily could have been our own. So when you look at because if a system to be developed, it has to have a history, it has to have a connection with the population for which it is meant to serve. That is why we are saying having the African solutions for African problems. True, because the modern medicine, of course, even Africa medicine is modern, but the modern medicine and studies have had a number of mistakes that have made, especially on Africa. In 1900, when this British and the other German doctors were in Africa, in Uganda particularly for a case, there was the disease which they call yawn. I don't know how that it is in our local language. But these doctors considered yawn, yes, it's called yaws as syphilis. So they were mixing it with the syphilis. And to the British, syphilis was taken as an African disease because Africans were decent, were immoral, and didn't have anything to stand for. So when a person in Africa, an African got the yaws, then he will not go to the hospital for treatment because, first of all, the stigma that you are immoral to have had the disease. Of course, no one is more than some of these guys. But, so you look at that disconnect, that and yet the Africans themselves had even ideas on how to treat some of these diseases. And we have seen the continued mistakes that have been made in the treatment, in the modern treatment. But you realize that, yes, we could have, as Africans, made mistakes in our treatment, but the African systems were a bit thorough because, first of all, the medicine they give you, they know that extract or that concoction that they are going to give you is not that very strong, that doesn't even have to say, take 1 mug or 2 mugs. If they are giving you Mululuza for malaria, you will swallow your mug and you will walk. Because the concentration is not, after all, that much. Of course, we also have some poisonous plants. So I think as the professor was saying, that as Africa, we need to have a system which is related to us. How do we handle our social issues? If a person is sick in an ordinary society, for example, how do we handle that? Even for those, look alone, those who go to witch doctors, because that's part of African society anyway. How do they handle the protocols of the treatment? Now, can we develop something along that line to fit into our medical system for Africa? We have had cases, for example, where women who give birth would trust a traditional birth attendant more than a medical housewife at the hospital. Why? Because you find a woman of that age going to the hospital, finds there a very young girl who is going to help her to deliver, and you know you don't match.
She has the one giving birth as a daughter older than the one helping to give birth.
Yeah, so that mismatch. Of course, we are saying that it's always good to give birth at the hospital, but so can we have a correlation between our practices and our systems so that there is some level of understanding and respect for our own systems than copying everything, which definitely in the long run may not be as effective as we think. And they've been talking for example, Cuba. I was in Cuba myself, and I've seen that I think much as this country has been under sanctions for long, but the systems that has also helped them to be inward looking. How do we survive exclusive of the rest of the world? And as we speak now, Cuba have their own vaccine.
They have their own Abdallah vaccine.
Yes, they have their own vaccine without waiting.
They're not struggling for
exactly. Talking of cancer, in Uganda now we're still amputating people who have cancer when they develop wounds. Cuba doesn't. They will just, because they say if they cut off your hand or off your leg, you are going to be a liability
to the society.
Yes. So the technology now allows them to still maintain that limb, but treat that cancer.
You hold it, Mtuta. We want to go for a break. I think on that cancer bit of it, Professor Dr. M here, they also have some sophisticated way of handling it. I think they now have some new technology. I've personally visited the Cancer Institute here in Uganda, and I'm impressed at what it says. In his earlier submission, he actually said, whether we are there by default, whether we are there by mistake, whether it's by design, or just by the grace of God, we are on a good trajectory. We're on a positive trajectory at the Cancer Institute. But we'll come back and talk about the things. And Professor Nantudia, you also help us understand the issue, especially of vaccine hesitancy amongst the people, because we talk about these things. And I don't know whether you also have some hesitancies with things like chemotherapy, radiotherapy, and quite a number of things. And we attribute these things to who we are, maybe as Africans and all the things. But we also need to understand, as a community, as a region, as a continent, do we have a way of managing these things? For example, Europe has what they call the EMA, their European Medical Agency. Do we have one as Africa? That EMA sits and says, this is the way to go. And once EMA says yes, then you'll understand that all the other countries under European Union will actually say that. In Uganda, when President Museveni says, let's lock down, another country says, no, it's business for us. We'll continue. And these are neighbors, these are relatives, these are people that you intend to plan and do things with, and quite a number of things. And we're seeing how to go about them. But we'll take a break. And when we return from that short break, we'll still continue the discussion of healthcare systems in Africa and how we respond to many of these emergencies when they break out. We'll take a break and return. It's the Pan-African Friday.
Live from UBC Studios in Kampala, this is Good Morning Uganda Extra.
Ekya COVID-19 kijja kugwa. If we get vaccinated now, observe social distancing, wear masks properly, sanitize or wash our hands with soap and water regularly. Together we can defeat this enemy.
It's no secret that ICT makes learning easy.
The strides made in our field couldn't be possible without it.
And now we can watch our favorite shows.
My radio is my best friend. UCC provides an enabling regulatory environment and policy guidance for healthy competition. We also facilitate ease of doing business in the communications sector through licensing, standardization, spectrum management, tariff regulation, rural communication development, and consumer empowerment. An informed consumer is an empowered consumer. UCC supports local content and innovations. Driving the development of a robust communication sector in Uganda is Uganda Communications Commission.
Live from UBC Studios in Kampala, this is Good Morning Uganda Extra.
Well, thank you so much. We continue the discussion on Pan-African Friday, and we talk about healthcare systems in Africa and how we respond to many of the emergencies that we get to. Now, in studios, we have two very important visitors, Dr. Jackson Orem, the Uganda Cancer Institute Executive Director, but we also have Professor Vinand Nantulia of the $1 Initiative. He's also the inventor of the Cuckoo Star vaccine for chicken. Now, when I call it a vaccine, somebody will say, oh, we already have the vaccine here. It's a vaccine for chicken. The inventor, he's a researcher, he's a consultant, and of course, retired. Like he said, he's lost some hair, and he's also lost the color of his original hair. But of course, that's why he's there doing quite a number of things. Professor M, let's get to you and talk about these issues. For example, he talked about cancer in Cuba and where we are today. We know we're trying to do our best, but yet again, we are looking at the entire health systems and whether we have something common that we do as a region or even as a continent. How we respond to it here, is it the same way that we respond? That is done elsewhere, and also maybe trying to find an African solution, like Professor Nantulia here submitted and said the Americans have their system that is run predominantly by the private sector and insurance. In Uganda, we have organizations, those that are called not-for-profit organizations. Then we also have those for profit, and when you look at what is actually happening here today, is we're seeing that it's now more difficult to manage or to treat COVID than to treat cancer. If somebody is diagnosed with cancer, they can know how to manage it. If somebody is diagnosed with COVID now and it gets to those levels, then you're selling your entire fortune and practically just manage a problem and do not know whether you recover. Come in, Professor Dr. Orem here, on especially how to manage cancer.
Yeah, I think the principle is always the same.
Okay.
You can manage something or you manage a disease depending on your knowledge of the causation of the disease and then the effect of that.
The cause and effect.
Exactly. So that means you can focus at one point at trying to prevent, and then you can focus at another time trying to make sure that you make good what could have gone wrong, treatment or specifically management. And cancer illustrates that very well. I don't want to really go into the nitty-gritty of what it entails, but the most important thing is to look at the lesson that can be drawn from something like that. And that is based on some of the challenges like the ones that the panelists here have alluded to. Number one is identification of what the problem is. We do know that we have a big healthcare problem in our hands right now. COVID is there. It is actually a health problem that has now spiraled beyond the rim of just health. and it's now becoming a problem of existence because, you know, it is affecting the community. So that is number one. And then number two, you need the people to respond to that problem. And I'm very happy the way my colleague here has brought it up, you know, do we have the people who know how to respond to a problem like that? Do we have the right healthcare workers? And are they well trained? And most important, do they have the right attitude towards, you know, what they are called for? So that calls for something which maybe we should have done even much earlier, inculcating in our trainees, in our healthcare workers during the time when they are actually undergoing that formative time to become healthcare workers, inculcating in them the right attitude. And that is actually what Cuba did, or what they have been doing, in that when we are crying here, trying to go to get health workers from there, what we are essentially trying to import from them is the right attitude and the right focus to a problem. And then, of course, the third thing would be to make sure that, you know, our healthcare workers kind of have the evidence for what they are doing. And that is what maybe sets them apart from others. We do have, actually, in our training institutions, we do have the right training programs, but do they practice the same way that they are trained? In other words, it should actually be that there is need for making sure that evidence-based practice is the way our people practice. And I think that is actually very, very key. Now, that brings me to a key point that my brother here brought up about the way we look at our innovations as Africans. And I think that is maybe one of the areas where there has been failure on the side of the intellectuals.
Innovation.
In our society, or people who have gone even before us, because they have not tried to make sure that they bring along the indigenous knowledge that we do have and make them empirical so that they can be applicable and integrate with the current knowledge, the way we know how things are being practiced. And that has kind of brought a division between what now others would prefer to say traditional practice, and then others would want to say modern practice. This should actually be integrated, because practice must respond to culture, you see? And that is where there is a disconnect. And I think moving forward, we need to begin to think about that. And that is an area of research in order to bring these two together so that they can move. Because there are so many things that actually we do have in Africa that can actually be modernized, and we can even teach the world how it is done. Then the third and the fourth and the final point, which I want to bring up, is what you have talked about, the integration of our systems. And that is very, very crucial. Because, as you know, the way things are now, you know, in order for Africa, or in order for the developing world to reach the level of the developed world, is going to take a lot of time, and it needs a lot of resources that the countries, the way they are right now, they cannot manage. And I give you a very good example of the East African community, and given that you wanted me to give the example of cancer that they have come up with. They have come up with a program where we are trying to create what we call regional centers of excellence for management of complicated conditions, and cancer being one of them. The advantage that kind of idea brings is that there are very few what I would call highly specialized individuals or human resources in the region in areas like that one. But if you can get such people in Kenya, in Tanzania, in Burundi, in Rwanda, and Sudan, and you make them to work together, that in itself is a big stride, because that means actually one of the things that you are trying to talk about of medical tourism or something like that, we can actually solve by making sure that our own people know that those type of rare cadres of individuals do exist within the region. And then number two, you make them have a system that can make them function in addition to communicating with one another. And then number three is some of the equipment, some of the inputs that is required for these areas. For instance, if you talk about this new machine we have just acquired at the Uganda Cancer Institute called a linear accelerator, we had to spend up to $4 million to procure that equipment. Now, you imagine, how many countries can actually at a time like that get that amount of money and spend it on just
one machine.
On just one machine. But then look at it this way. What about if the East African countries kind of come together and they pool their resources? They can actually get this equipment very easily and then make the citizens of the region kind of come to one place to kind of access those types
the services of that
services of that nature. And I think that makes sense according to what he has just said about, for instance, issues like the border closure. That means actually we need porous borders in order for people to access health. So that is just one example. So in conclusion, what I can say is that we do have the resources, we do have the capacity in as far as expertise is concerned within the boundaries of our countries, but there are very few. But if we enlarge that to the region, then we get more. But if we even do further and have it at a continental level, that means actually we can even have, for instance, issues like the COVID vaccine manufacturing solved, because by now, at least within the borders or within the African continent, there should be at least a place where they will be manufacturing vaccine. I'm very sure the capacity is there in terms of the know-how, but what is lacking is organization and maybe injection of financial capital.
Professor Nantulia, come in here to add on what Dr. Rem has talked about.
Yes, let me add on, thank you, on the regionalism, regional cooperation and so on. We experienced it with the first lockdown in the response, and we had strategies in Uganda which were not accepted by Tanzania, strategies which were not accepted by Kenya. The three countries would meet, and then we didn't have what we should have done, which is make the whole process smooth.
Across the region?
Across the region, across the borders. Because we have communities living at the borders. We have got communities there with a home on one side of the border line, this theoretical line, and another home on the other side. And you see the Agria warriors,
Agria and Mude, yes.
Yes. So this is what we needed to do.
Even in 2012, when Kiprotich won the gold medal?
Yes.
The second to Kiprotich was also called Kiprotich.
It was also Kiprotich.
Now the winner was a Kiprotich from Uganda, and the runner-up is a Kiprotich from across the border.
Right. So you have got Awori as a presidential candidate in Uganda, and another Awori as the vice president of Kenya.
In Kenya,
and they are from the same home. So we need to do that, and we should have done the response much better if we were together. Now this question of the COVID. The final solution to fighting COVID is vaccination. There is no other. And we need to have the vaccine in the country. Money lost, money what, what, we need to get the money to buy the vaccines and look for the vaccines.
Members of Parliament are demanding ministers and the COVID response team to tell us where the 29 billion shillings that came from donations from the public went.
Yes.
We're now asking for the money. We need to know who stole our money, who ate our money, and what the money did.
That's priority number 2. The priority number 1 is let's mobilize money now and import the vaccines, because the final solution is vaccination. There is no treatment yet. There is no treatment.
Talk about the hesitancy of the
treatment. Where treatment means cure. if you are infected with the COVID virus, is there a treatment you can give that can cure that person? We don't have. In the whole world, there isn't. What there is are this, what we call supportive care, supportive treatment to enable your body to fight the virus. You recover because your body has fought the virus, not because you've been given the medicine. Oh, no. But we can give you supportive therapy. You have got fever, okay, let's control the fever. You've got a headache, okay, let's control the headache. You are having body pains, let's control that. You can't breathe, let's manage you, let's assist you to breathe. But there is nothing that is there as a medicine for cure. And that must not be misunderstood. And in fact, for all viruses, we don't have cure for viruses, do we? No. But we have vaccines for preventing the infection and for controlling the epidemics. Now, when the pandemic struck, developed countries mobilized money and financed research institutions to develop vaccines and to develop drugs. This went on very aggressively, and they were invested that countries even committed to buy billions of doses for if the vaccine comes out of a particular facility or this other facility. That's what they did.
Actually, they bought them before they were made.
They bought them before they were made. It was a system of financing. Yes. Now, the vaccines came along. We have no vaccine doses for Africa because they were bought in advance. So WHO has struggled and struggled through COVAX to get some vaccine, and Uganda has benefited and got some vaccines before, about 846,000, and then recently 176,000. But that is not what we need. What we need is we need to vaccinate more than 22 million Ugandans. That's about 50 million doses of the AstraZeneca vaccine or the vaccine which you give twice. But remember that as we go along, there will be annual boosters required because this is a flu type of infection. So what is Africa doing? In Africa, we are not producing any vaccine. For now. But we are going to produce. In Africa, we are not working on vaccines, developing vaccines our own, except in Uganda. We are doing that.
It's only in Uganda that we're doing?
Yes, we're doing that. We have got research groups, research hubs that are working on the development of vaccines against COVID. Pretty advanced too. And Africa, the African CDC has proposed that we need 5 vaccine centers in Africa.
That's great.
One in the North Africa, one in West Africa, one in Central Africa, one in Southern Africa, and one in Eastern Africa. And we, Uganda, are saying that we are better placed to host that one for Eastern Africa.
For
Eastern Africa.
For Eastern Africa.
Because we already have vaccines being developed locally in Uganda. We have got research groups that are working on this. We've been working on this. I happen to be a vice chair of the Presidential Initiative on Epidemics.
Preside,
which is running this.
Okay.
So, we are also going to build a factory. We talked about the Coxstar vaccine. We have made a case, and the President has given us the go-ahead and written to Ministry of Finance to provide us with the initial funding to build the factory which will be able to produce vaccine against COVID and other vaccines. And this, not for Uganda market alone, but for the regional market. We are fronting that as one of the initiatives that Uganda is going to do, because we need the vaccines. Now, COVID is one challenge right now, but there are others coming because the population is rising and we are encroaching on forests and swamps, and that's where the microbes are. So today it's COVID, the next day it will be another one. And we have had the discussions with the president, and he understands fully that what we are setting up is a national capacity to respond to any emergencies in the future, so that we start now as a lesson we have learned from COVID.
Correct.
And that is really, really adorable that the president has done, and he's driving us very hard, I can tell you. But we'll do it. We'll get there.
So COVID has also come with some positive things in there. It's a very big revelation, Professor Nantulia, to actually say it's only Uganda in Africa that is trying to develop a vaccine.
Yes.
And
we have gone very far. We have 2 lines that are almost coming to the level, as the president was saying, to the level of testing in animals.
At that level?
Yeah. Has it been easy? No, it has not been easy.
It hasn't been easy.
But do we have the knowledge? Yes, we do have. We have people well trained. And we just put them together and said, okay, you scientists, biochemists, physicists, let's sit down together. Can we work on a vaccine? I had been challenged by the president. Say, why are we not working on vaccines? I said, Your Excellency, I'll get back to you. We got them together. Said, okay, if you're going to find a vaccine against this disease, where are the possible entry points? We identified them. They are the same that the other guys in Europe and America are also pursuing. Same. And we said, okay, let's start. Who is going to work on this? We got a group to work on one. Another hub, we work on this approach. Another hub, we work on another approach. And this work is being done and is being funded.
We have that capacity in this country?
Yes. And it's being funded centrally.
Talk about the vaccine hesitancy, Professor.
Now, for the construction of the facility to manufacture, do we have the know-how in the manufacturing? Yes, we do. Because we have a facility which is already manufacturing vaccines. But except that it's vaccines against poultry diseases.
It's not unfortunate.
So,
I think
it's about, and the technology is
it's a starting point.
The technology is the same. So, it's about revamping that. And so, we are going to construct the factory, the state of the art, to produce these vaccines. Not only COVID, but other vaccines.
Until we get to our own vaccines, or until we get to producing our own vaccines.
Until we get to developing our own vaccines, what can this factory do? We can do it another way. And in fact, that's the way that technology transfer works. You begin by what we call fill and package. We can bring raw materials elsewhere that people have already developed. The vaccine is here, it's in a big tank, and say, okay, give the tank to us. We buy it, and we bring it here, and we package it, ready for use. At the same time, you are constructing the facility for actual production of the vaccines. We will do that.
I think I'm learning something.
But before that, let's buy.
Exactly. Now, before that, let's buy. And we talk about the buying now. And we talk about the different types on the market today. We talk about AstraZeneca, which is with us here for the COVAX facility. We talk about J&J. We talk about Pfizer. We talk about quite a number of these. And Ugandans think about traveling and moving abroad. Are they saying, if you vaccinate me with a AstraZeneca jab, then you're failing me to go to America? You're failing me to go to Germany and elsewhere, because the EMA says no with AstraZeneca. And we have these problems. Somebody says, I'll take a back seat and wait. Now it's not even about treating themselves or keeping themselves safe, but it's about, if I go to AstraZeneca today and tomorrow I'm denied a visa to England, what shall I do? Or to England is okay because Britain also with AstraZeneca. But somebody says, if I took AZ today, and tomorrow I'm not supposed to go to the United States. You're killing my future. You're killing me. You're killing my opportunities and stuff like that. And people are having these problems, looking at them. And I think that is why there's maybe silence on pushing for vaccination.
No, let me, first of all, there's a lot of information that circulates on social media. You know, one of the things that was useful when we only had UBC. UTV and Radio Uganda was that the information would be uniform.
And managed well.
And managed properly.
Uniform and authentic.
And authentic. Now, what we have today in the social media is not authentic.
Not uniform?
It's not uniform. It's misleading and so on. People are told that when you go and get vaccinated, you fall sick. You get COVID when you get vaccinated, which is complete nonsense. When you get vaccinated, it doesn't matter which vaccine. You can have some side effects, some reactions.
For every vaccine?
Yeah, but for every vaccine. You may have a pain at the site where it was inoculated. You may have some fever. You may have some muscle pain, etc. It is common to all vaccines. The worst vaccine I've ever had was actually cholera vaccine. That one knocked me out for a whole week.
Cholera vaccine?
Cholera vaccine. And yet protection is only 60%. So when you get the COVID vaccine and you get some side reactions, which are, you may have a headache, you may have a little bit of fever, you may have a bit of weakness, and this lasts about 72 hours. After that, you are okay.
72 hours is only 3 days?
Yes. But people have made a big story out of this on social media, that in fact it causes COVID. It's not, it does not. Two, there's this idea that when you are vaccinated, you can never get infected. That is not correct. Because it depends on the dose of infection you get. It depends on how your immunity is able to cope with the infection. So you can't get sick when you get vaccinated, when you are infected after vaccination. You can. What the guarantee is that when you look at people that have been vaccinated and then they get infected, the chances that they will die out of COVID is almost zero, as long as their vaccination was efficient. And it doesn't matter whether it is AstraZeneca, whether it is Moderna, whether it's Pfizer, whether it's J&J. It doesn't matter. The end result is the same. Now, there is in this business, of course, politics, the geopolitics of globalization. Now there is a law being pushed in Europe that if you are vaccinated using AstraZeneca vaccine made in India, your certificate cannot allow you to come to UK or to Europe. However, if you are vaccinated with AstraZeneca made in Europe,
Oxford.
Yes, you can. This is geopolitics.
Because it's AstraZeneca,
it's the same
vaccine. The challenge is made in here and made in
here.
Yes,
because India makes it as under contract. It's not a different vaccine for India. So these are issues which circulate, but it's a lot of politics in it. We know. You can even see the politics of buying in advance all the vaccines and making it unavailable to the low-income countries. This is geopolitics. It's geopolitics. So all the vaccines, whether you get Pfizer, you get AstraZeneca, you get Moderna, you get J&J, they all protect. Also Sputnik, the Russian one, it protects.
And something.
Yes, it protects. But in geopolitics,
Dr. M.
Yeah,
you're the experts. The rest of us are just looking at you.
I agree entirely with what Professor Natolia is saying. I think now what is required is for the leadership in the country or in Africa to kind of look at the big picture. The big picture is that we need vaccination because vaccine is the only sure way of controlling this pandemic. Because there are two ways in which vaccine is going to help. Vaccine is going to help at the level of the population. It's going to prevent acquisition of new infection. It is true, it may not be preventing 100%, but at least if a good proportion of the population is vaccinated, that means actually the level of protection at that level is very high. So that's number one. And then number two, even at the individual level, the vaccine has the protection of preventing you getting into the severe form of the disease in case you did get infected, despite the fact that you are you are vaccinated. It prevents death. That is actually a very key thing. Okay. So we should look at these two levels, that given that there is advantage at the population level, and then there is also advantage at the individual level. That means actually the vaccine should be more a priority than treatment. Because if I got a drug for treating COVID, I'm going to administer it, and it is going to work at the level of just the individual. I'll save one person. But if I emphasize vaccine, I'm going to first of all save the population, and then I'm also going to save the individual. So that is why actually that prioritization need to be understood and emphasized.
So whichever way we go, we need to advocate for a vaccine. That's where we need to go. There are things also being talked about, but I think you're the experts. And well, I'll talk about specialization first and foremost. Now, like we look at all the things you said. We need to have in sub-Saharan Africa, where we have many of these epidemic issues. That's why I think we are in for public health. And we tend to think we can manage our issues that way. Ndugu Akolia talked about medical tourism in India, but I also noticed that why many people go to India is because they go for specialized treatment. And I'll tell you, we go to India because that's where we have the best pulmonologist. That's where we have maybe the best oncologist for this. That's why I have the best maybe for that. And we talk about that. We now have a problem that of all the things that it affects the lungs. I do not know of more than 10 pulmonologists in this country. I don't know. When you go to the Lung Institute, and so it is, are we also focusing to that issue, that we can have a problem where people's lungs, because we're now hearing many of the people who are getting onto ventilators is they are scanning, they're doing scans, and they find that, I even do not know why it's out of 25, but they say out of 25, the person's lungs have been eaten by maybe 18 out of 25, 20 out of 25, and literally they do not have lungs anymore. And that's why it is. Are we also looking at those specialities, because we now see it as a problem? Professor Nantuja.
Now we are looking at the issue of training of medical workers. I'll pick it up from where you left it. We are training doctors and nurses, but we are not preparing them to respond to what the task of human life is all about, and human health. When I was serving on Makerere University Council, I had initiated the idea that, for instance, when you recruit a kid to go and study law, is the kid going to study law because he thinks it is a very flamboyant position to be a lawyer, you can make money to be a lawyer, or does the kid go there to really serve the system of justice? How do you select the kind of kid that should go and do law? And I introduced that idea together with Professor Twino, who was the acting dean of the law school. We said, no, set up an aptitude test. Let all those students that have applied to do law.
So you are the brain behind pre-entry exams?
Yes. Let those kids...
So many will hate you.
Yes. Those kids that have passed, give them an aptitude test to find out whether they really know what they are going to do. And that is what you need, so that when the kids come, they actually learn the art of being a lawyer. So then you don't have the crisis where they go to the Law Development Center after getting the degree and they fail to get a certificate
of practice.
Yes. Now, in the medical field, we need to have a similar approach, that we know how to select the kids that really are made to be nurses, to be doctors, to be people to serve others and save lives.
Exactly.
Otherwise, The kid will come in with 3 A's and 5 A's and 6 A's and so on, and all he's interested in is, when I get in there, I'm going to be rich. So what do? When they are still medical students, they start recruiting patients on the sideline and getting bribes from patients to be connected to the physician. That's what they do. So we need to have a system that can select people for this. That's what they do in Cuba.
Exactly.
Yeah, they do that in Cuba. And they do it, yes?
Not cutting the issue. Now saying about that, in Cuba, a medical doctor in Cuba, to a level of a consultant, earns $200 as a salary.
Yes.
And that is what he earns to keep
That's what
him.
he earns to keep him.
But of course, government gives them a house, gives them and the rest.
And so on and so on.
Yeah. But the salary.
So they come in to save life, not really to make money.
Not to make money.
It is not about how much money they get.
Yeah. Now, one of the examples I saw when I was working in Thailand, when a young doctor qualifies and is posted up country, the salary he gets is equivalent to the salary of the undersecretary in the ministry. So that salary is not the driver. You go and serve. But we need a lot of change in there, and then a system where we shall reward the kids, the doctors that are doing well, and to send them for postgraduate training, including specialization. Now, how does India end up as a
destination for medical tourists?
This is what Indira Gandhi did. Indira Gandhi came in, established a fund for students to go and study anything as long as they were going to US, UK, Germany. The kids go there and specialize. They have specialized in physics, specialized in health. At the same time, the government introduced a system for upgrading their institutions, upgrading their hospitals, upgrading their universities. When those kids finished, they actually could come back and apply the knowledge that they gained.
Upgraded institutions back home.
Yes, and that's what has happened. So you have those very good hospitals in India. Many of the doctors that are running these are still living in the US. But for 3 months, they come back to work in that facility. And they have others that are going up to US and so on. So it's about a strategy for continuous improvement of our healthcare system. If we have got our Uganda Cancer Institute, how can we bring it up even further? I was talking to Professor Riem before we started. There's something else that we are working on which can add even more power to the Uganda Cancer Institute to be a regional center. This is how it is done.
But at the same time, following up on his contribution, you know, the identification of who is going to study what, or the actual knowledge,
the selection also,
the knowledge amongst scholars that, I mean, students that I need to study ABC, because I've had interaction with many of our people here, including my relatives and their friends. But to an ordinary child in Uganda knows when I go to a university, I'm going to do law, I'm going to do medicine, I'm going to do engineering. Anything beyond that?
No.
And yet there is a vast, there's a lot of things. A person you're talking about the lungs, we're talking about eyes, we're talking about ears, the TNT. These things are not promoted amongst, or the areas of study are so limited that we have people going for the already known courses, which, and they major yes, because they're going to give them money. But we're not looking at the human aspect, the social responsibility. Even as we study, how do we be of use to our populations? And there are people who go there because they have seen their parents or their relatives die without help, say, no, let me go and study so that I'll be able to help someone, to save a life. The type of the pre-entry assessment is talking about. So I think it's also important that while we try to build this capacity, we start it from back in schools to find people who are likely to do this. This person can do this, this person can do this. So that cadre identification and a training maybe will also be good to help us have more of, because already we're now saying, people are saying.
Well, again, that maybe if I can also come in here, because yesterday actually we had news that Honorable Seninde had been appointed as Director of Mobilization at the NRM Secretariat. Cadre identification and placement. And this sent me thinking, of course, from what Professor Ntula has actually said, that I think the Ministry of Education or government should have a department of career identification and movement. Yes, I think that's very, very important, because schools used to have career masters that for career guidance.
And the best thing they did was to tell you which combination
to do
career, which combination, but not which career.
So now I think the Ministry of Education really needs to come up with a career. A career identification and involvement department. It will help us on that. Now, I also get a very good example from the Catholic Church, that when they are training priests, the recommendations have to come from your parents. Yes. Your parish priest, then you go to the community, then even when you're at the seminary, there is that constant checking on you until when, so that by the time you come out, you're really a priest, you are even convinced of what exactly you're coming to do. Now, even President Yoweri Museveni has always said it, that during those days, when they were recruiting the army, they would look at the height. Are you tall enough? Then you would join the army. Now, even in the villages, people would say, this kid is disturbed, let him go to the army. But now, when they started the process of professionalizing the army, you must get a recommendation from Chairman LC1.
The system of recruitment.
The system of changed. And that's why you can see there is a little bit of discipline in the army. So it is now that we should also go back on the drawing board, our education system. That it's not a question of looking at grades, who has passed what, no. Who is better suited to pursue a particular course and serve society.
I want to, on the issue of specialization, I have not had Dr. Oremia, on specialization, how do you do it at Cancer Institute or with cancer?
Yeah, I think that's a very good point. The fundamental issue is that actually health or health professional development should be looked at as something like a vocation. You know, I like the example you are giving of the Catholic Church, because when you are going to become a priest, you know first of all what you are going into. You are not going in to be a businessman. You are not going. You are just focused.
There's certain things that you know that once I get into this thing, I will not do that and that and that and that.
Right. Yeah. So that is the same way for health, and I think in a way we have lost that, because people are going in because they're thinking of other things, and this has actually also been made worse because there are certain areas which seem to be a bit more lucrative, and they kind of tend to draw more people. So I think we did a small I would say a small experiment at the Uganda Cancer Institute, whereby we started going to schools and talking, because previously it was very difficult to actually get people to think about cancer as an area that one would want to specialize in. So we did an experiment where we started going to schools and talking to the students about the opportunities for career in cancer, the great research that is done in the cancer area. And then within a very short time, we started seeing more and more people, because those students eventually go to the university, and then from the university, actually when they're at the medical school, they now come to us. More and more people are now coming, more pupils are coming, and they want actually to specialize in cancer. So that is actually one way of increasing the base of specialists in areas which are relatively difficult or relatively not well known as of now as a place where one can develop a career. The second point which I should bring is that a study was done before coming up with this program of the East African Community of the Centers of Excellence, whereby they found out what is it that takes people away from the East African region to go to India, to go to South Africa, to go to Israel, to seek cancer care. And one thing was very evident. What they're looking for are specialists. So the next thing is, what about if we produce those specialists locally? Don't you think we are going to save a lot of money? And that is the essence of the East Africa Center for Excellence.
They go for experts, yes, and the specialists who we can actually bring here.
Therefore, we need to provide money to pay for the specialization courses.
Correct.
For those trainees.
Correct.
It should be a priority.
Yes.
Correct.
Money to pay for the specialized courses.
Training.
Training.
Yes.
Correct.
Just like India did, we take them, bring them back here, and then we know that we have an expert who you would find in India. He's actually at the Cancer Institute.
That's right.
Yeah, you can have an hybrid.
Okay.
Both.
Okay, Ndugu Akol, we're running out of time. You have something to conclude, yeah?
Yes, my conclusion is...
and maybe if you have a specific question to any of the professors here.
Actually, my question is about culture. Yes, how we get the best cultural practices fused into our medical system. I'll give an example that we have people who have special gifts in Africa. There was a time in Uganda hospital where actually they even created a room for somebody who would make people's or repair people's broken legs, broken bones.
In Uganda, those are the ones we call varibao.
Oh yes, that's about, even if you fall, it's a question of getting measurements with the stick, the part that got broken. And at a particular time, he will do it himself, and eventually trying to fix the part.
So your question is on?
So my question is exactly, how do we really use our cultural, fuse our best cultural practices into our medical practices, the current medical practices? Because like as we put it, you find that some of the wives, actually women, fear going to a midwife because of age. But in the olden days, these things would come with age. Yes, that actually if you'd come with age, that you have to become a midwife, at least at a certain age, so that even people can believe that yes, you can handle.
You can administer this to me.
Yes.
Ndugu Mtuta, your final submission, and I think you'll just ask a question to the two gentlemen in studios, because we have 5 minutes, which they will have to share and respond to your issues. Yeah,
it is to do with the type of disease, because most of the diseases we're struggling with today are actually foreign diseases. Africa has had its own epidemics. We have had even these choleras and the Ebolas. We are not sure actually if they originated here. So we are fighting against all these other diseases. But the issue, of course, as he mentioned, the issue of funding, because to be able to sustain, we need to have research, the body of that information that will help us to, if it is talking about production of vaccines. Now, what are we looking at, especially as the African group of professionals, in terms of research and the development of our own systems? I mean, it is even weird that...
work for us.
Yes.
Okay, we'll start, I think, with you, Professor Nantulia, responding to the issues of the gentleman in your closing shots, then Dr. M.
Yes, I think first of all, it's been a very lovely discussion, and the issue of adapting technology to the community culture is very, very critical, because as you said, a mother of 40, they're going to deliver, and the midwife is aged 18, 19, 20. That is not quite Yes. So, but at the beginning, we had a system where you qualified as a nurse in its different grades before you come to do another course in midwifery, and that allowed the midwife to be a little older than the nurse and the assistant nurse. And I think it's important that we take that into consideration. With regard to the selection of people going to do specific courses, that is really critical, and we need to have in the Ministry of Education a system for guiding students.
Yeah.
Just like in the medical school, we should have a system for guiding students in what they can specialize in. Because what you start with is a general degree or a general certificate, but there should be a system for identifying who could possibly go into which specialization. Now, when you look at the fixing of bones, that's why the surgeons were called misters. They are still called misters because they were not supposed to be doctors. Yes, I was a beneficiary of that. I had a broken leg during when I was young, running and playing football, and what saved me was just someone in the village brought the sticks, tied them around nicely, told me to rest, and then within a week said, okay, start moving around with the stick, and that's how I got. But yes, but that technology is adopted by the scientists. That's why they put on plaster. Yeah, but so we should not be copycats. We should be thinking as we move forward. Yeah.
Okay.
Actually, on that one, I know we're running out of time. Last time we had discussed here then I said, it's not even this witchcraft of ours. Maybe there's something that can be
picked from it.
Yeah, if it can be started, and because all this technology started as witchcraft anyway. But
and maybe to those who died before this technology, if they came back today, they would actually think it's witchcraft.
It is witchcraft.
Maybe it would be witchcraft to those resurrected today.
And witchcraft has gotten very. We need to adapt from witchcraft the way they do it, because it's full of psychology. Correct. And when you look at the patients that are in hospital under ICU or HDU, one of their biggest problems is psychological.
Psychology.
So the gentleman you described, who simply says, you give me what I trust you, that whatever you give me is in my interest.
It's what's happened with witchcraft.
Is in my
Do what you can
That's
do.
what happens in witchcraft. Yeah.
Do what you can do,
Yeah.
Tokele save me. Thank you, Professor Nantuli. Yeah, Dr. M.
Yeah, thank you. I think I agree with what Professor Nantuli has just said. This has been a very enriching discussion. And regarding how to harmonize the cultural practices into what is actually what the normal that people in the health field are doing. To me, I think the most important there is going to be research. There's need for a lot of understanding, and trying to create an atmosphere which makes, these people with their knowledge and their craft to kind of have the ease with which they can interact with the system as it's now. But the key thing I would say is the attitude in as far as training of our young people are concerned, and then them looking at actually the profession not from the perspective of what is going to come out at the end, but as their contribution to society, as being useful members of the community. And then maybe my third and final point is that there is need for us to re-engineer our health system. And we need to kind of break this barrier that is between public health and
private.
Yeah, exactly.
Public and private.
Exactly. We need to break that barrier so that we kind of make sure that we are responding to the same thing. And we should take a good example from actually the UK, where in this pandemic you hear two areas which are very important in the response. that is the Public Health UK and the National Health Service. You have these two together, you have the formula for overcoming a situation like the pandemic we are in.
Just 1 second. There has been a lot of talk about private sector overcharging patients that are on ICU.
Yes.
The cost for ICU is the same all over the world.
Critical care treatment
is the same all over the world. It's expensive all over the world. There's nothing unique about our private hospital.
The best thing is to do what you can to avoid getting to that level.
Number one. Number two is how do you handle that? We said in Cuba you handle it by government investment. In US you handle it by insurance companies. But the cost should not drive us astray. The cost is the same anywhere in the world. It is expensive.
Okay. Well, I want to thank you so much, Professor Nantulia Venand of the Kukusta, but of course, Venand is the deputy chair of the preside, and quite a number of things. He's been there, done quite a number of things, and I'm only happy personally, on a personal note, that I went to the same school with Professor Nantulia. Professor Nantulia is an old boy of Tororo College, and I know Zayowana may not want to listen or hear this, but you have no choice. I went to the same school with Professor Nantulia and others. Thank you so much, Dr. Jackson Orem from the Uganda Cancer Institute. You've been very engaging. We love the conversation. You've really given us quite a number of things to learn from. And of course, we push it back to policymakers, like Akol said. When you go to India, when you go to Germany, when you go elsewhere, what do you see there that you don't think should be here? That you save yourself the cost of traveling, because you travel when you're sick, and yet you would be treated here and just work and go back home. But thank you so much, Akol. Thank you so much, Mututa. Thank you so much, our guest, and of course, our producer, and everybody who has made this show possible. For God and my country, we wish you a blessed weekend. Let's continue observing the SOPs as we continue fighting COVID-19. Let's not relax because of the figures coming down. When we hear that the infections have come down, it's because of the lockdown. So let's do what we need to do. We should now demand and say, let's get back to life again and mess it up. We don't want to lose it because we're trying to manage it. For God and my country, my name is Jagana Semakola Ziksoka. Blessings and goodbye.
Live from UBC Studios in Kampala.